take her out cocaine.
For Marine Corps veteran Thomas Sanford, the war in Afghanistan is over, but he has yet to know true peace. In a suburb not far from here, every night he puts his 3 children to bed, tucks them in, closes the door, gives his wife a kiss goodnight, and then he goes on his evening tour. He tours all the doors in the house, all the windows, makes sure they're all locked and secure. Comforted that they are, he gets into bed next to his wife, but sleep does not come. He lies there, and despite the oxycodone he takes for his chronic hip pain, despite the trazodone his doctor has prescribed for him to help him to sleep, he lies there, wide awake. He reaches over to the bedside table, takes a couple of Ambien, also prescribed by his doctor. And finally, he begins to drift out. He's now in and out of sleep in that never land, when all of a sudden he hears a sound. He bolts upright. What was that noise? Was it an intruder? Did he forget to lock the door? He's out of bed again, checking all the doors, all the windows, all the doors twice, 3 times. Finally, he's sure they're all secure. The perimeter is secure, the way he secured the perimeter for his buddies in the desert of Afghanistan. But now he's wide awake. He sits down at the kitchen table, his heart's pounding. He reaches for his friend, who's also his worst enemy, Jack Daniels. And then there are the flashbacks. The flashbacks come predictably when he's in a crowded supermarket or a department store, or when he's underground in the subway in the T station. The flashbacks of the horrors, the horrific scenes of the brutal, gruesome bodies he saw in the desert of Afghanistan. The flashbacks also come unpredictably, as when his wife opened up a bottle of cleaning solution, and it triggered a memory of the smell of the explosions he witnessed. Thomas doesn't talk to his doctor about all the alcohol he drinks. His doctor asks him. Thomas doesn't really fess up. He doesn't tell his doctor he drinks alcohol about a quart of whiskey a day, or how often he drinks it. It's every day. Nor does he divulge all the memories, all the pain he experiences on a daily basis. His doctor tries to send him to the mental health professional, but Thomas has been there before. It's a waste of time. He doesn't want to do the counseling. He doesn't want to do the group talk therapy. He's been through that all before. He's taken the medications. Nothing works. It's a waste of time. How do we break through and connect with these veterans? How do we make an engagement that will allow us to help Thomas Sanford? Alcohol and substance problems are highly prevalent among American veterans. Among veterans returning from Iraq and Afghanistan, 4 in 10 veterans report on a regular screening questionnaire that they have an alcohol-related risky behavior. And half of those would have criteria that would qualify them for an alcohol use disorder, a more serious condition. Yet, only 1/3 of those veterans report that a physician ever talked to them about alcohol use. Furthermore, substance use problems are even more challenging, harder to measure, but at least as far as we can tell from a variety of studies, more than 1 in 10 veterans from Vietnam, the Gulf War, Iraq, and Afghanistan has suffered from and suffers with a problem related to illegal substance use. The Department of Veterans Affairs and the VA Boston healthcare system where I work has been trying to address these problems. For example, we now have mandatory screening for alcohol use problems with a 4-item questionnaire such that 95% of veterans across the country entering a VA system have been screened for risky alcohol use and alcohol use disorders. Turns out that about 1 in 4 veterans who's gone through this screening actually screens positive for risky alcohol behavior. Yet, only fewer than half of those veterans has ever had any kind of intervention, whether it's a brief communication with the clinician or referral to mental health. Less than half of those have had anything done about their identified risky behavior. We know that the screening and the potential intervention is challenging to do, and unfortunately it often happens, despite 95% of the veterans undergoing screening, it happens in a superficial, compulsory kind of way so the team can check the box and get it done. Why are we not reaching our veterans? Why are we not connecting with Thomas? There are at least 3 barriers that have been identified. First of all, it takes time. We know the primary care visit is 15, 20, or even 30 minutes long, but there's a lot to get done. And talking about screening for and counseling about alcohol and substance use takes time. Second, we're just not comfortable doing it. We're not trained. Most primary care providers and other healthcare professionals in general report that they don't have the skills to talk to patients about alcohol and substance abuse. Third, the patients don't want to talk about it. They're embarrassed. They're concerned that divulging information about alcohol and substance use will influence adversely their relationship with their primary care provider, or, moreover, they're concerned about disclosure of information that might lead to legal ramifications. To address these and other barriers, we propose a technological solution, a relational agent like Tanya. Developed by Timothy Bickmore, professor of computer science at Northeastern University, relational agents build a relationship with the patient through simple, easy-to-comprehend language, through the use of a touchscreen computer or a mouse through which the patients point and click the responses on the right side of the screen. Relational agents have simple language, have human-like gestures, have very natural-appearing eye movements, and a human-like posture that allows them, in a variety of studies, demonstrated to build a relationship, to connect with patients, to ensure that they will have a long-term connection with this person, this cartoon-like character. In conjunction with Professor Bickmore, we developed a relational agent to screen for alcohol and substance use at VA Boston and pilot tested it last year. We recruited a total of 60 veterans for 2 separate studies. In the first study, we recruited 30 veterans and had them screened with Tanya and then with 2 live interviewers who actually happened to be 2 Harvard medical students. We screened the veterans and we asked them using a validated NIH-based questionnaire about their alcohol and substance use. In the second pilot, also with 30 veterans, we screened using the same NIH-based questionnaire with Tanya, the relational agent, and then with a text-based computerized questionnaire already in use in the VA. In both of these studies, we found that veterans were at least as likely to divulge information about alcohol and substance use to the relational agent as they were to the live interviewers or to the text-based computerized questionnaire. We also found, in talking with the veterans following the screening, that they were comfortable talking to Tanya, that they trusted Tanya. They said they could use this kind of technology to divulge not only information about alcohol and substance use, but about other sensitive topics, about their family history, about a sexual history. So we found that veterans will engage with this kind of technology, and it seems to be effective at assessing substance use and alcohol use. Our next step is to carry out a large randomized trial of this technology, not only for screening, but also for intervening, to see if we can actually improve the care of alcohol and substance use among our veterans. We also hope in the future to be able to expand this technology to other problems in healthcare: medication adherence, diet, exercise, smoking cessation. Within the VA, our mission is, as President Lincoln said over 100 years ago, to care for him who shall have borne the battle, and for his widow and his orphan. Our goal is to improve the healthcare, the delivery of healthcare for all the men and women who've served the armed forces. Our goal is to engage them, to reach out to them, to make a connection with them, so that someday, just someday, we can improve the care of people like Thomas.